Thank you so much, Julie, for the introduction, and thank you to the Psoriasis Association for inviting me to the meeting today. It's a huge pleasure to be joining you all, and as Julie has said, we've been undertaking a piece of work at the University of Manchester to really understand the epidemiology of psoriasis. Some of you may have joined us last year in Manchester, where I started to kind of lay the ground in terms of what we plan to do. So hopefully today I'm going to kind of cover some of the key findings. But first of all, I'd just like to kind of acknowledge some of our research team at Manchester who's been integral in delivering this piece of work. Alison Wright, Paul Dimmock and Alex de Fatima Cobra, who are all part of our research team, and they've been busy mining some of the available data sets, so they're the ones who really are the engine room, I think. So I'm going to be talking specifically about the epidemiology of psoriasis, and epidemiology is really one of the pillars of medicine because it helps us understand how often diseases occur in different groups of people and why. And this information, as already highlighted by Julia, is often important because we can use it to plan and evaluate strategies to prevent disease, and we can use it to guide the management of patients in whom disease has already developed. As part of our work in the Global Psoriasis Atlas, we're kind of compiling the kind of largest ever data set on the epidemiologists of psoriasis internationally. And the latest update to that work was published in the British Medical Journal back in 2020. We've just been in the process of the last 18 months updating this data set, so we're looking forward to kind of sharing a new version of the Global Psoriasis Atlas on World Psoriasis Day later this year. But these reviews actually often throw out lots of really important questions that are unanswered. We often find when we look at the data that there are highly marked variations in the epidemiology of psoriasis around the world, both in prevalence and incidence. And these variations occur not just between countries, but actually when we look at studies within the same country. And when we dig a little bit further into that, what we often find is much of that variation can be explained due to the way people have conducted those studies, different operational definitions, different data sources, etc. That often makes it challenging to really kind of draw a line under how common psoriasis is. So we have a variety of different sources of variation in terms of the data sources. That might be electronic health record data sets that are available in a number of countries. For instance, the UK, we're very fortunate. We've got a national health service and virtually everyone is registered with the NHS, so we can mine that. And several other countries have data sets like that, but many don't. So they rely on different sources. You know, in some places, for instance, in Africa, where we've visited as part of the Global Psoriasis Atlas, we've had to conduct field studies. So going house to households and screening individuals and understanding disease occurrence. But the way psoriasis has also been characterised often varies in terms of whether that's a self-report from individuals or whether it's a diagnosis from a clinician, and actually what type of prevalence of psoriasis they're talking about. Is this lifetime prevalence? Has someone ever had psoriasis? Or actually, do they have psoriasis at that point in time? So you can imagine all these different studies, you know, kind of looking at all the different ways of kind of measuring it. And what we're trying to do in the Psoriasis Atlas is put a framework around that so we can start to draw out some signals out of that particular data set. But what we found looking over this data set is that very few studies have actually reported on the incidence of psoriasis. So we've really been pushing this agenda. And when I talk about incidence, what we're talking about is the number of new cases of psoriasis that are appearing over time, not just those that are already in the community. And even fewer studies have simultaneously compared trends in incidence, prevalence, and mortality. And that's really important to kind of look at all these measures at the same time, because if we start to see signals that the prevalence of psoriasis is increasing, it's really important to know, is that because there's more new people being diagnosed with psoriasis? So in other words, is the incidence increasing? Or another explanation could be, is it whether patients are nowadays living much longer with psoriasis due to improved life expectancy? So they're living longer, the pool of people with psoriasis becomes bigger and bigger over time. So some of these answers have been really difficult to kind of unravel because nobody's looked at these factors at the same time. we took forward a study that used a data set from the UK up to 2023, and we were the first time to look at this in psoriasis. So here, just on the figure to the right, you can see this relationship. So if you look at the bathtub, that's kind of the prevalence. You know, we're trying to get a count of how many people in the country have psoriasis, and that can be influenced by the number of new cases that come into that pool, but it's also influenced by the number of people who exit that pool as well, I think, coming through. So the importance of looking simultaneously at these different factors is really important. So the work we've undertaken very recently for the Psoriasis Association is to kind of update those estimates of psoriasis. The latest available data we had only went up to 2023. And we were asked to take forward a number of research questions. How does the epidemiology of psoriasis vary between different ethnicities in the UK? This is something that we've never had any data on previously coming through. And we're very fortunate that the data set that we use, a collection of records called the General Practice Research Database, have introduced in the last 12 months an ethnicity record. So they've mined the records from general practice and hospitalisations and created an ethnicity record. So for the first time, we're able to look at kind of how this may differ between different ethnicities. We're also asked to look at how the epidemiology of psoriasis may have been impacted by the COVID pandemic. We know that lockdowns and restrictions to care, etc., may have influenced the number of people presenting to services, and that may have, influenced the findings. So we were very keen to kind of observe what might have happened over that period and whether or not recoveries, kind of set in. And then thirdly, whether the prevalence of psoriasis continued to increase in the UK since we last reported it in 2023. So in 2023, we started to see an upward trend in the number of cases. So we're very interested to roll that forward another 10 years and see, whether or not that is increasing still. And if so, as I mentioned, whether this was due to changes in incidence or could it be more accounted for by improvements in life expectancy. I guess there's another fourth research question that we actually undertook as well. So it wasn't something the Psoriasis Association asked us, but we did all the above for people with generalised pustular psoriasis as well. And that's where the piece of work that Julie referred to earlier has really kind of fitted in most recently in helping to influence some of the policy decisions. So I mentioned the data source we use. This is the Clinical Practice Research Data Link, and it's anonymised health records drawn from general practices in the UK. Very, very large sample of general practices in England, Scotland, Wales and Northern Ireland. And we're able to kind of look in that data set at the extent to what people are exposed to, what prescriptions they're prescribed, what diagnoses the GPs are making. We can look at laboratory results, we can look at vaccination history, and we get some information on the demographic data as well of those individuals. So this data is fully coded, there are patient identifiers removed at source, so we can't identify anyone in that data set. But the beauty is we can also link that data set then to a number of other nationally collected records in the UK. In particular, hospital episode statistics. So we can look at kind of admissions to hospitals, and also we can link to the ONS mortality records. And that's important because when a death certificate is submitted, that's the official record for the cause of death. So over our study period from 1998 to 2022, we identified a very, very large cohort of individuals with psoriasis. So over 1.2 million people are within our study set. Here you can see the distribution in terms of gender, ethnicity and region, in terms of where these individuals are contributing to the data set. Slightly more women than men within that data set. Strong preponderance for white Caucasian population, but for the first time we're able to kind of present kind of individuals from Asian background, black background, mixed background, as well as other regions. And then you can also see, not surprisingly, the data is dominated from England because it's more densely populated within the UK compared to Scotland, Wales and Northern Ireland too. So what did we find? So overall, over the study period, we found that the prevalence of psoriasis was increasing over time as well. So we looked over that period of 25 years, and we found that the prevalence over that period averaged out was 2.75. So it's pushing up continuously within that. We found that women had a slightly higher prevalence than men within the data set. But what was most striking, and what we were particularly interested in, is how this varied between different ethnic groups within the population. So you can see for the white Caucasian population, that's well over 3% in terms of prevalence. For the Asian population, it's 1.55. For the black population, 0.67, occurring far less frequently. And not surprisingly, the mixed population sits in between that coming through. We're also able to kind of stratify those results in terms of incidence. So this is the number of new cases over patient time. So here's just a plot just showing you kind of over time how that prevalence value is changing, and it's stratified by women, the purple line at the top, and men in terms of the blue line at the bottom. And again, just stratifying that analysis, showing you how that varies between the different ethnic groups. Pink purple line at the top is white, the Asian population next, the mixed population, the green dotted line, and the black population, the bottom line at the bottom. Okay, so you can see the distribution between the different ethnic groups. We also looked at annual patient prevalence by age groups, and not surprisingly, we were seeing higher rates in the older groups coming through within that figure. So our next question was to, after looking at prevalence, to look at the incidence. So this is the number of new cases that are coming into the data set over time. And what we found that, if anything, this was relatively flat. It certainly wasn't going up. If anything, possibly a slight decline in terms of rates coming through. But we're particularly interested around this point. People will remember times of 2020, 21 around the COVID. And you can see, quite clearly within the data, there was a massive drop-off in diagnoses of psoriasis as a kind of secondary effect of the pandemic. People were not presenting to the same degree into kind of healthcare services. And it's taken a little bit of time, I think, for this to start picking up, I think, within process. With the new cases, we're also able to look at kind of age of onset, and you'll see there's kind of what we describe as kind of a bimodal distribution. So this has been reported previously in the data, so we're reassured to kind of see that again within the data. In terms of the late onset psoriasis, not much difference between rates between men and women, but as you can see for the early onset psoriasis, this is, I think, where we see the differences, where it seems to be presenting in girls at a much earlier point than what it might do in males coming through. We looked, as previously, at mortality rates as well, and what's interesting over time. So here on this figure, the red line is representing people without psoriasis, and the blue line is representing people without psoriasis. The red line is people with psoriasis. And you can see for people with and without psoriasis that mortality rates are reducing over time, which is, in one extent, good news. We're seeing improvements in medical care, etc., cardiovascular disease management, etc. So that's good. I guess what's less kind of welcoming is there's a mortality gap that's clearly evident between people with psoriasis and those without. And over time, this mortality gap is not closing. So I think this is a really important area of future research here, of really understanding what's driving this and actually tackling some of those determinants, I think, because it's a persistent pattern that's emerging across this data set, and it's not closing, I think, the gap. We looked at age-specific mortality rates, and as you can see, what we're finding people with psoriasis, so that's the orange bars for psoriasis versus controls, the rate of death is actually occurring slightly earlier in the population than what it is, I think, for people without psoriasis. So that was the work we did on psoriasis, and then we turned to GPP. This has been an interest in the Global Psoriasis Atlas for the last 18 months. We've conducted a number of studies, but there's so little data about GPP available. We took the opportunity while we had access to the data to conduct a similar study looking specifically at GPP. Obviously, GPP is less common than psoriasis, but actually our cohort that we were able to identify was just under 1,800 people that we were able to track. Again, 2/3 almost that population were women compared to men. 86% were white, about 9% were Asian, and just under 2% were black, and 3.3% from that mixed population, I think, coming through. The work we could do on GPP, because it was only kind of recorded in the hospital records, is restricted to England. So this is just data from England on this date. So if we look at the population and the cases we found, the prevalence rates and the incidence rates here, you'll notice that there are over 100,000 people in this case, and the incidence over 1 million people, and that's just because it's a much rarer disease, so you get an estimate in whole numbers coming through. But if you look at how we stratify the data by gender, you can see that this presents more commonly in women than men, and it presents more commonly in white and Asian populations than what it does in the black and mixed populations, I think, coming through. You can see, again, the prevalence stratified by gender for GPP and also by ethnicity. And we also looked again at the age bands as we've done previously for psoriasis. So we're starting to get a more detailed picture of how often GPP presents alongside psoriasis. But we also started to look at survival data as well in this population. And this figure, I'm just showing you kind of data. The blue line represents people with psoriasis that we could look at mortality rates in. And the red line is people with GPP. So you can see that GPP is associated with greater mortality than what psoriasis is itself, quite distinctly. We're able to stratify that by men and women, and again, the men seem to fare less well than women on both counts on that front. Because we had access to the ONS mortality records, we were able to look specifically at what were the main causes of some of those deaths that were recorded on the death certificate. And the three principal causes for both psoriasis and GPP related to respiratory disorders, neoplasm or cancer, and circulatory disorders. So these are all really important areas, I think, in terms of targeting future interventions to hopefully reduce some of the mortality kind of rates that we're seeing within this population, and in particular start to close that mortality gap. So I think the programme today is going to explore some of these issues around kind of behavioural factors, and I think that fits very well with the epidemiological data. Alongside that, part of our work programme at Manchester developed the SoWell resource set with the Psoriasis Association several years ago. And again, some of the messages and resources that are available really fit with some of these areas. We know often in the populations of people with psoriasis that they may smoke more than what we see in the general population. We see that figure repeatedly every time we go into surveys or we go into other data sources. We often see as well that levels of alcohol are consumed much more frequently. And we also often see that people may be more overweight or obese, I think. So there are resources there to help support individuals, and we'd be delighted to kind of circulate these details a little bit further alongside all the discussions that are going to be held today. So I'm going to stop at that point, but I'd just like to thank the team at the Global Psoriasis Atlas. Many of us are here today. So, Chris Griffiths is our director, and he's here today. But also we've got Thomas Rogers and Alice Silk, who are our administrator and programme manager. Please come and talk to us if you'd like to learn more about the Global Psoriasis Atlas. But thank you for your time.